Okay, hello. Today is a new lecture, and we're going to talk about alopecias. So, there are two types of alopecias. One is called non-scarring alopecias, and the other large group is called scarring alopecias. And that's the first important thing to uh, look at. Now, sometimes it's difficult to tell what is scarring from what is non-scarring. Therefore, you could be misled. So many a times, if you do a biopsy of the scalp, that will tell you whether it's scarring or non-scarring. And it's very important to do that because otherwise you'll misdiagnose the patient. When you do a biopsy from the scalp, I would do a 5 millimeter punch biopsy. I would do it from what appears to be maybe normal hair to and then take a second biopsy from the area that has the disease state or the area that's changed. So two biopsies would be the way to go. 5 millimeter punch from normal and a 5 millimeter punch from the abnormal. So under the non-scarring forms of alopecias, which we'll go over today, you've got one alopecia areata, trichotillomania. That's when someone pulls out their hair. Tractional alopecia is such as when one has a constant pull of the hair where they do not remove the hair as in trichotillomania, but the pressure from hot combing or pulling and ponytailing the hair causes that type of tractional alopecia. And then we got the different fluviums, of course, syphilis, androgenic alopecia. This is rare to see alopecia with psoriasis or seborrheic dermatitis. That would be very, very severe to cause hair loss. I've never seen that. And then in severe dermatophytic infections, where the fungal penetrates the hair follicle, you could definitely see hair loss. And then the hair shaft abnormality is where the hair breaks off at the root or just above the root, and it's not a form of alopecia per se, it's rather a form of hair breakage. So let's just show that, okay, that there are things we know as hair breakage, which need to distinguish from the true alopecias. So keep that in mind. If you see hair breakage, it's hair breakage. It's not alopecia. And there are different conditions that cause that. So we're going to go one by one and discuss these entities. Alopecia areata is probably the most common form of alopecia, second to normal female pattern or male pattern baldness due to changes in hormone and genetic predisposition. The most common form of alopecia areata shows an oval or round-shaped, non-scarring type of hair loss, and it's pretty clear to see, such as in this picture. This is another picture of a round patch of hair loss. When this hair loss, the non-scarring alopecia areata hair loss, forms around the fringes or the borderline of the scalp, it's known as ophiasis. It could involve any part of the hair, with the frontal hair, the occipital hair, the hair around the parietal area. This is also part of the ophiasis type of description. So ophiasis just means that the hair loss is around the edges of the scalp, not so much central. Once in a while, we're fooled by seeing someone who's got a diffuse type of alopecia areata, and without a biopsy, one would be hard put to understand that clearly. So you don't have to scare the patient by the time you're going to do a biopsy. Tell that patient that you need to take a little piece of skin from the scalp to be able to differentiate the exact nature of the hair loss and the cause of it, so you could talk to them about proper treatment. Now, when alopecia involves the scalp, it could be called alopecia totalis. When alopecia areata involves the eyebrows and the rest of the hair areas, such as the eyebrows, eyelashes, the underarm hairs, and the pubic hair, and even hairs all over the body, then it's known as alopecia universalis. Alopecia areata can involve sometimes just the bearded area, as in this man, and it still looks the same, round patches of hypopigmented to erythematous skin, and it's not the erythema that you see from inflammation. It's just normal skin that looks red because that's the patient's normal skin. The best treatment for these, besides topical steroids, are very mild injections of intralesional cortisones. When it involves the eyelid, you can see that's what it looks like. And this is a patient with alopecia totalis. And patients that have alopecia often have nail pits. So if you look at their nail plates, you will see in many cases when the condition is severe, pitting in the nail plate, which also causes a disturbance in the way the nail plate looks. You can see the same thing happens here at the distal part. There's some distortion of the nail, and this is pretty much what happens in this situation. The next topic, which is trichotillomania, is also a disturbance in the growth of the hair. And this occurs when somebody pulls their hair out. Now, often there are telltale signs where it looks like the hair breaks off, but most patients will not admit to the fact that they pulled their hair. And when a biopsy is done, there's a pathognomonic description of the type of hair loss that you can tell by doing a punch biopsy. So the punch biopsy goes a long way. It's hard to tell that this is trichotillomania without a good history. So I would propose doing a biopsy to make sure that that's what it is. Unless, of course, the patient's mother or somebody else tells you that there's a history of, nervous habits, and that's usually the reason that the hairs are pulled. Patients are not really mentally sick. They're just really a little bit uptight, stressed out, and they find pleasure in pulling hair, believe it or not. There's some growth of new hair in the center. That doesn't really mean anything. So in a workup of alopecias, one needs to do a blood test, okay? With CBC, CMP, T4, TSH, ANA. And the reason we do that is because when you have iron deficiency, anemia, or any form of anemia, you get hair loss. When your thyroid is out of whack, you get hair loss. When you have diabetes, you get hair loss because there's a decreased vascularity to the hair follicle. When you have a positive ANA, you get hair loss, as we could see in systemic lupus and even discoid lupus. And Dr. Jerry Shapiro from NYU's is who sometimes we send patients to see. There's, of course, something that is going to be coming out soon enough, which is a form of a biologic that is going to be approved for alopecia. It's like it's going to change people's lives, but when one is going to use them, it's going to have the same contraindications or same concerns that we use for patients with psoriasis and other conditions. The NAAF, the National Alopecia Areata Foundation, and the Children's Alopecia Project are areas that you could go to find information about the latest news and how you could help these patients. And when it's non-scarring, the hairs will tend to regrow because the root has not been damaged. And so there's better hope for these people. The mainstay of therapy right now for adults and or kids are the class 1 steroid therapy with clobetasol for 2 weeks and Lidex for 2 weeks. And you can see we have we use a little bit of a less strong topical steroid for the beard like Lidex and triamcinolone and Westcort. And if you want to be more aggressive, but you got to watch out for possible, side effects. The most common being atrophy of the skin and depression of the area is using intralesional steroids. And I don't even use a 2.5 milligram per ml. I inject even a lot less than that. And if you mix that in a 1 ml syringe, we give a tiny amount of a dose of like 0.05 cc per area. You can be more aggressive on the scalp than you can on the face, but still warn the patient, even on the scalp, that they may get some depressions. And if you fear doing that on the face, do not inject unless you have experience with intralesional steroids, because you will cause a problem which will not go away. It's called a lawsuit. So just use topical steroids and leave the intralesional injections to people who've done that in the past and were good with it. You need to always question your judgment, and therefore, if you think there's a disease that you may be missing, by all means, do a punch biopsy, because anytime you deal with a chronic situation, as I've explained in the past, it's better to be on the safe side and get a biopsy diagnosis to support your clinical suspicion than just be guided by clinical suspicion and find out that you've been wrong, embarrassed, wasted a patient's time, and maybe even a condition where the patient's health will get worse. So if you're dealing with a chronic condition, do a biopsy. It's nothing that invasive. Now, there's a lot of people afflicted by that. And one of them is the candidate who ran for Miss Delaware, and she had a wig on, and but she told everybody that she had that. Sometimes Latisse for eyelashes is helpful, and when we had the Puva therapy, it it definitely did help patients with alopecia totalis and universalis, but it's a very long and painstaking procedure because they've got to step into a light box, take some pills, cover their eyes with special goggles for 24 hours after they do that. So it's really cumbersome, but patients with severe hair loss go to desperate measures, and therefore when the biologic is finally approved and in use, it's going to make a lot of people happy because they will opt to do that because they're embarrassed by hair loss. There's always a potential for regrowth, but when the hair grows back, it's usually white. And many a times, the hair regrowth doesn't last for a long time. It tends to kind of fall off at different times, and it's unpredictable. You might want to take the family history and see if they have any other autoimmune diseases. Sometimes it's related to atopic dermatitis, Hashimoto's thyroiditis, celiac, lupus. These are just associated other immunodeficiency diseases. There's nothing you can do about it, but it's of note to know if this is the only condition or whether it's related to some other ones, you know? So, in the treatment of alopecia areata, for now, we do intralesional injections. We draw up 10, Calnock 10 with normal saline. As in the recipe we're showing, and this is what is injected. The intralesionals vary depending on every patient. The face you really need to watch out for. The scalp you could be a little more relaxed with. These are some other treatments. Minoxidil for widespread. Send them to Dr. Shapiro. Puva therapy, which we do not have anymore. Anthralin therapy, which is disgusting because it actually turns the skin a different color, and it's an irritating compound. They found out that irritation to the skin is somewhat helpful, and so on and so forth. And a lot of people use other forms of irritants, and I do not recommend them because they're really a pain to use, and they do have some side effects. It's just better to try to treat them aggressively with topical steroids and intralesional. And when I see a condition that's really widespread on the scalp and moving rapidly, I have the patients come in every 2 weeks to get a shot of intralesional steroids. I mix it with lidocaine, and I usually inject the periphery of the lesion to stop it from expanding outwardly. So, in my opinion, that's what I've used, and that's what it works very well. This is a summary of what we just discussed. So read that at your leisure. Sometimes you could see it's very hard to distinguish between alopecia areata and trichotillomania because sometimes they look somewhat similar. You can see here some loss of eyelashes, which also occurs in alopecia areata. And when the hairs grow back in alopecia areata, sometimes you'll see what they call exclamation point hairs. These are very small hairs that just come out of the hair follicle of different lengths. And I've never found that to be extremely helpful. But people talk about it as if it was like, wow, I see exclamation hair points, must be alopecia areata. I don't find that as something that you really hang your hat on. Now, tractional alopecia is something that one gets when the hair is being pulled, as in this picture, by any sort of instrument. The constant pressure on the hairs will probably cause this. And usually, if the pull is here, you can see you get this alopecia from that area where the pull was probably the most severe. And here you could see small areas of tractional alopecia. And we most commonly see it in the African American patient who has a history of hair treatments using hot combs and other forms of attractions to straighten out their hairs. Now, In talking about telogen effluvium, now telogen effluvium, what happens is that any form of stress causes the anagen to go into a resting telogen cycle. Now let's go back a bit. 80% of all the hairs at any given time is in the anagen phase. Then, as the hair slows down in growth, it goes through a transition of a stage called the telogen, the catagen phase, and then eventually it goes into a dormant stage, which is the telogen phase. So there's certain factors that cause the anagen phase to go into the resting phase, and as a result, the hair falls out. When that stress is removed from the follicle, there is regrowth of the hair, but the regrowth of the hair starts from the root of the hair, and therefore it takes some time before one sees the appearance of new hair growth. So what kind of stresses do this? Any kind of stress. For instance, one of the most common stresses I see is after childbearing, a woman might come to see us and say, you know what, I had a full set of hair until I gave birth, and I've lost a lot of my hair. And when you ask them, how long ago did you give birth? They'll say, well, 4 months ago. And you could tell them that within the next month or two, she's going to start seeing new hair growth. If somebody goes into a coma, for instance, you pass out, you become comatose, you go through surgery, puts a lot of stress on you, you could see that type of hair loss as well. So any sort of physical stress to the body, such as very rapid weight loss, will put that type of stress on the hair follicle, sending it from an anagen phase to a telogen phase. The hair kind of falls out very quickly, and when that stress is removed, the hair then regrows. When you're not sure, you do a biopsy, and in a biopsy, we see miniaturation of the anagen here. In other words, a hair follicle which looks large and has a bunch of layers around it, becomes telogen, which has now become much smaller, and a few of the layers from the anagen cycle, the telogen cycle, are now gone or they've changed, and that's how a diagnosis is rendered through these type of observation on a skin biopsy from a hair-bearing area. Again, if I was going to do a biopsy, I would take one from the affected area and one from the unaffected area to make it easy for a pathologist to be able to distinguish the normal from the abnormal, because there's a low variation in all of this. Anagen effluvium, anytime you hear the word effluvium, means that you're messing with the cycle of the anagen, catagen, telogen phase of the hair follicle. In the anagen cycle, disruptions can also be caused by chemotherapy, steroids, medications like Accutane, and other types of medications, vitamin D and acetotrasin. Now, one of the things that we don't see a lot of, but you need to keep in mind, is secondary syphilis. Now, secondary syphilis has the appearance of a moth-eaten type of appearance, such as this. But in addition, in secondary syphilis, you also see hair loss from other parts of the body and a moth-eaten-like appearance on the upper extremities, lower extremities, and elsewhere. So if a patient comes in, you show a mulled type of hair loss. And then on examination, you notice, even if the patient doesn't, that he's missing areas of hair from the upper lower extremities. You need to think about that type of thing. And this is something else that needs to be added to your blood test. So let us go back and see if the blood test showed an RPR. No, it didn't. So what we're going to do is we're going to say, oops, we forgot the RPR. No, it did show it. It's right here. See? So when we paid attention, we see that the RPR is something that we need to do. Otherwise, we might not pick up syphilis. And even though there's no other lesions on the genitalia of a male or female, this could be a telltale sign of secondary syphilis. So we don't want to miss it, because then syphilis becomes tertiary. And as a result of that, you get into problems with the heart and problems with the nervous system. So you could save a patient a lot of unnecessary paralysis and ill health if you pick it up based on hair loss with those type of patterns. Now the next non-scarring alopecia is alopecia due to androgenic causes. Now I'm not quite sure what female Christmas pattern tree looks like, but if you look down here, the Ludwig scale tries to describe a female that goes from this to this, or from here to here, or something that's even more accentuated. One has to rule out patients that have polycystic ovarian disease or congenital adrenal hyperplasia. They tend to have loss of hair on the scalp, but they also have hirsutism, acne, and irregular menses. So how do you pick that up? You got to do a little bit of a hormonal blood test if this is what you're considering in a patient that has other manifestations of polycystic ovarian disease. And you ask to get the serum testosterone level free and total, the dihydroxy androsten sulfate, the DHEAS, the iron studies, ferritin, the thyroid function test, ANA, and RPR. Male that have the androgenic alopecia or male pattern baldness usually begin with bitemporal balding and the balding in the occipital area. And the two kind of, the occipital area moves forward, the temporal area moves backwards, and then eventually they're joined. And this is what the appearance will be in a male pattern of baldness. So in a male, one could try to stop this falling out by using topical minoxidil. In a third of the time, it stops hair from falling out. In a third of the time, the hair regrows. And a third of the time, it makes no difference. So it's a really mixed picture. So there's a good chance that the topical minoxidil will work, but it may fail. And then one has to apply it twice a day. And if one sees an improvement, then obviously one should continue using it. It's effective in about 2% of women and 5% of men. So it's very important when one is going to treat that which appears to be a male or female pattern baldness, that certain baselines are done because we will be treating chronic conditions. On one hand, we were doing biopsies of the scalp to make sure we're not missing a diagnosis. On the other hand, now that we're convinced that we're dealing with male or female pattern baldness, on the male and female, one should get a blood test consisting of the rest of the tests that we discussed, such as a CBC, CAM profile, RPR, a thyroid function test. But in addition, we would get a free and total serum testosterone and FSH, which is follicle stimulating hormone, and LH, which is luteinizing hormone, which when are low, the luteinizing hormone, follicle stimulating hormone, should show an elevation and the free and or total testosterone level. So once these are done, if they come back normal with PSA in the male, then the male could be treated using Alopecia 1 milligram, which works very well. And the reason we do the PSA before starting is just to make sure that it's not going to masquerade an elevated PSA, because Alopecia can masquerade BPH and or prostate cancer by reducing the PSA level. This does not have to be done in a female. That is the PSA, just the other blood test should be done before committing to a chronic long-term use of either medications, minoxidil or minoxidil with Alopecia. So as you can see, there's bitemporal baldness in this situation, and here it's a diffuse hair loss that we can see in the female. Again, a diffuse hair loss we see in the female. By the way, the new treatment that we are conducting in our offices is PRP injections. That is a treatment that works very well for especially the female. The 60 mLs are removed from the patient. It's spun down to a 10 ml aliquot. It's placed in a high speed centrifuge, which is very, very high speed centrifuge that concentrates the platelets at the bottom of the centrifuged blood. We then remove the platelets with a long needle that is wide, and then that is injected into the area of the diffuse hair loss. In this, for instance, in this area, we inject this into here, and if the patient has androgenic alopecia due to female pattern baldness, she will grow such a bush of hair that is unreal, and this will last for about 2 years. If this is done in a male, the procedure lasts for only 3 to 4 months. So unless someone needs to gain hair very quickly for some occasion, I don't recommend it for males, but in women, it works so well that it lasts for a long time. It has to be repeated probably every 2 years, but it's a wonderful procedure. And you could look at that procedure on our website. So this is the female pattern. It's usually a diffuse hair loss, thinning of the hair in the male. It's the occipital, bitemporal, and then the connection into a horseshoe type of hair loss. And you can see that in every color here. Now this is a picture of an androgen secreting tumor in a woman presenting like male pattern baldness with severe hirsutism that presented some months before that, and it's not a typical look in a female where you see mostly a diffuse hair loss, and here it's almost like a male hair loss with bitemporal hair loss. Okay, another non-scarring type of alopecia is tinea capitis. It's most common in children. I've yet to see it in an adult. When it gets very, very severe, one sees a carry-on. Now, a carry-on is really a boggy spot of inflammation, and it's usually associated with lymphadenopathy in the neck. They need to be treated with systemic antifungals, otherwise it does not work. Some dermatologists also add systemic steroids for a couple of weeks to reduce the inflammation. That varies amongst physicians as to the way they treat it. The old-timers tended to do that. It's probably not necessary unless the patient's complaining of severe pain due to the inflammatory nature of the problem. Once you see that, you'll be very impressed with the severity of the inflammation. It's pretty severe, and you can feel nodes quite easy. When treated with systemic therapy, it probably takes about 2 to 3 months of treatment before the lymphadenopathy starts to recede. And you just follow patients, as I do, with getting blood tests for any of the systemic antifungal to make sure they have no adverse reactions in the liver. So you usually get a CBC with DIF and a liver function test every 3 weeks, and I see the patients back every 4. Therefore, they get the blood test a week before they see me. Sometimes it's hard to tell that the scalp is involved with the fungus unless some hairs are plucked out using hemostats right by the roots, and the roots are placed on a slide with a cover slip and some KOH, and you can see the fungal elements along the edge of the hair follicle. Now, there are different types of hyphae, some that are along the outside of the hair shaft and some that are inside the hair shaft. And that is the ones that are inside the hair shaft are called endothrix. The one outside the shaft are called ectothrix. The endothrix infections are harder to treat. They take longer to go away. The typical course of an ectothrix fungal infection is about 3 months. The endothrix would be a few months more. So realize that this is not such a good sign. These are what these hyphae look like. They're very, very thin. They look like that. That's about the only one I see branching here clearly. These are just cracks in the slide here. But this one is where it's at, right here. This, if you follow the arrow. These are endothrix spores. You don't see hyphae here. It's hard to find infections like this. The most common ones are exothrix, such as these. The exothrix, this is the hair shaft, and the fungi are here. Hair shaft, and they're on the outside. As I said, they're painful, boggy. They will pus, and you really need to be aggressive when you scrape it because otherwise you're not going to see it. After a while, you just gain the experience that even without positive KOH, with lymphadenopathy, you could actually clinically state that it's a carry-on. Now, there's a whole host of scarring alopecias. They're described in this slide like pseudopelade, lichen planopilaris, lupus, morphia, folliculitis decalvans, dissecting cellulitis. Now, of these, I could tell you that the most common ones include lichen planipilaris. That is associated. It's a form of lichen planus, and most of the time, I've not seen this. I don't think I've ever seen it associated with lichen planus of the body, but that's what it refers to. It can be associated with lichen planus of the body. Okay. The other one is discoid lupus. When they say lupus erythematosus, diffuse lupus does not scar, but discoid lupus scars, and you'll see atrophic areas of skin. Dissecting cellulitis is also more common, but we don't see that often. So probably the most often one that we see is probably lichen planipilaris. And then you always need to think that if there's some sort of scarring alopecia and it looks like a nodular plaque, and there's scattered nodular plaques throughout the scalp, you could be dealing with metastatic disease. And metastatic disease, one of the most common ones are urinary. Anything from ureter to the bladder tend to land in the scalp, and lung, CA, and then and the female organs like female, like the uterus carcinoma is something that tends to metastasize. But renal is probably one of the most common. Okay, kidney. When I say urinary, mostly urinary kidney. The most important thing when you're dealing with a scarred type of alopecia where you cannot see the hair follicles, you cannot see hairs coming out of the hair follicles, is you absolutely have to do a punch biopsy, okay? And sometimes you may need to do 2 or 3. So you might want to do one from the normal area, and you might want to do one from the involved area, and you may want to do one for immuno. So let's say one from the involved and one from the uninvolved, and one immuno. Because if you're dealing with, say, lupus, if it's discoid, 25% of the time you'll see a positive immuno, and sometimes if it's systemic lupus erythematosus, it's non-scarring, but you might pick up a positive immuno. So you could do up to 3 and not be wrong about doing that. Now, in some of these cicatricial or scarring alopecias, there are different names that go along with the type of infiltrate that one may see. Frontal fibrosing alopecia and pseudopelata broke and alopecia mucinosa, which is a precursor to mycosis fungoides or T-cell lymphoma. Okay. It's something that needs to be observed. There's a lot of mucin in the biopsy specimen, and that's how one diagnoses it. Pseudopelag is basically thought of as being an end-stage type of scarring alopecia, meaning that you're never going to get any regrowth of hair. End stage, no regrowth. and hard to tell what condition preceded it. And fibrofibrosing alopecia is one of its own diagnosis, and lichen planopilaris is this, and that. Then you got discoid lupus erythematosus. That's lichen planopilaris. And I've had the most satisfaction in treating this condition with intralesional steroids because it made a huge difference in my patients' lives. It actually kind of stops the condition if you inject it with intralesional steroids. It's phenomenal. What a big, big, big change in hair loss, you know. Okay. Now, there are infiltrates which are seen in neutrophilic type of cicatricial or scarring alopecias, and these are the two types of alopecia areatus. They're hard to treat because neutrophils are acute and usually very buggy. And dissecting cellulitis of the scalp is one of those neutrophilic scarring alopecias. It's difficult to treat, and you'll see pictures of that. There's different, it's sometimes associated with hidradenitis suppurativa and acne conglobata. So I imagine that off the record, one would be able to treat them with Humira, which was just approved for hidradenitis suppurativa, and probably get this thing going, but there's no FDA approval for that. Would I do it? I'm not sure. Depending on the patient and the severity, I might have to have them sign a consent, which tells them that it's a non-FDA approved medication, but more than likely will work. And this is something that, you know, it's chronic, it's inflamed, it's painful, and you'll see it looks terrible when you look at a scalp like this. This is what it looks like. It has these sinuses, okay, whereby they drain. They're buggy, they're painful, they drain. They can form tracts like this, and sometimes they form these little nodules. So this is dissecting cellulitis. This is very, very common, acne keloidalis. You see what you do is you see keloids. They're little tiny keloids. Usually they start when the scalp is in shape very, very low to the hairs are shaped very low to the scalp, to such an extent that the hairs that comes out of the opening of the hair follicle is caught on the rim, and instead of going right out of the follicle, it actually penetrates the side of the hair follicle and goes into it. And it becomes irritating to the skin, and in an African American, it develops these little tiny keloids. And the trick to this, when you treat it, is to make sure that the patient's neck is not shaved so close to the skin. And the other thing is, what I do is I numb these patients with a mixture of lidocaine and a little intralesional steroid injected into each of these follicles, and then I shave it with a blade, these little tiny lesions, and I micelle it, or you could cauterize it. I micelle it, and you know, they'll come back, they'll have a few more, you do it again, but as long as they don't get their hair shaved so close to the scalp that the screw type like hair doesn't go into and irritates the surrounding of the opening of this hair follicle, they usually tend to do pretty good. See, and these patients do not have a history of keloid for the most part. So that's important to know.
So it's kind of like a pseudofolliculitis, kind of.
What was that?
It's almost like a pseudofolliculitis barbe, kind of, where the hairs kind of going back
Yeah,
in, kind of.
yeah,
Okay.
that's correct. Yeah, it's like Erica said. Erica's saying that it's a lot like pseudofolliculitis barbe, which is true, but you don't usually see the keloids forming a pseudofolliculitis. But the thought is the same. You can't shave the hair so close to the skin that it irritates the opening of the hair follicle. So that's how you want to treat patients. And you see these little tiny keloidal lesions. Inject it with lidocaine and some intralesional steroids, and then shave it, and you'll get some pretty good results. It's a close up. And you can see there's lichenification too, because this itches, and so the patients tend to scratch it as well. And they think they could scratch it off. So now sometimes they almost look like they're formed from like a folliculitis, perifollicular tiny papules that become keloidal. In this situation, if it's not due to the shaving of the hair, and you can see this is a Caucasian a person, it's due to a folliculitis. So if you treat the folliculitis with topical clindamycin and maybe benzoyl peroxide at night, you can shave this off, treat the folliculitis, and this one will not recur. This is a patient, I guess, of before and after, where sometimes that had a surgical procedure done to remove the acne keloidalis. So this whole area was cut out, and this is what you see. This linear scar from the surgery.
Is this considered doll's hair then?
What's that?
Is this considered doll's hair? Like, this is how it looks pretty much? Is that what they call doll's hair?
I'm not sure what they call that, but it's a pretty thick keloid. But some patients go through this procedure. Now, folliculitis decalvans. Usually what one sees here is tufting of the hair, like like the hairs that are seen in dolls. A bunch of hairs come out of the hair follicle. They're sometimes associated with a suppurative folliculitis, meaning there's pus, and it may be due to bacteria, so one needs to culture that. It could be painful, may be genetic, but not always. And let's see what it looks like. If you could look at this, you see there's 2 or 3 hairs coming out of each hair follicle. That's what they refer to as like the doll look. It's scarring. You don't see hair follicles coming up. There's some pus, like pustules. There's probably a scab here. They look like there's some pustules on the periphery. So that's folliculitis decalvans. It's scarring alopecia. Now this central centrifugal scarring alopecia is very common in the African American population. What you usually see is a middle-aged to an older African American woman coming and complaining that she has hair loss. And when you examine her hair, she's got diffuse hair loss involving the center of the scalp and the parietal areas. When I mean central, it starts centrally in the center, and then it goes towards the parietal temporal areas. And the hair becomes very thin, and it does this progress. It's very slow. It doesn't happen overnight. It takes years to occur. And we need to do, again, a biopsy is one of the most important way of diagnosing these conditions. There's certain things we see on biopsies. And then the way we treat it is we treat them with systemic antibiotics, minocycline, and usually it holds the condition. Discoid lupus is something that's easy to pick up. 20% of patients with discoid have systemic lupus, so you need to do a systemic workup. Such an easy one would be an ANA. You could also send one to a rheumatologist to work the patient up. When you do the biopsy and you're trying to exclude DLE, you want to get a direct immunofluorescent. That's why I said in some cases you're going to do 3 biopsies. Or you could do 2. You could do one from the normal skin, one from the abnormal skin, and take the biopsy from the abnormal skin and take an number 11 blade and just cut it in half from going down from the epidermis into the fat. Drop half into an immuno bottle and the other half into an H&E bottle. Okay, and that would be from your lesional skin. You'll have 2 bottles there, and then you get a normal one from the normal scab, so it could be looked at and compared to the abnormal.
When you split it in half, do you have to use a number 5 punch so you have enough skin for an HB and
Yeah, it's best to give the pathologist a good sample.
Okay.
But if you're not going to do 3 for whatever reason, then at the least you could do is take the 5 millimeter and cut it in half so that you've got something to show them. Usually with these conditions, you'll see a lot of atrophy and scarring. So you can see in a Caucasian, you got this slight scaling, white scaling, but it's atrophic, it's scarred. Same with here. This is something, punch-out lesions of I guess, lichen planopilaris. So this is lupus. This is lichen planopilaris. Most of the people I've seen with lichen planopilaris, which have not been a lot, even though we have a huge practice, have not had any other signs other than their scalp. So that's good because it's a horrible condition to have. And this is a very typical picture. You see this erythema. This is the hair loss. Usually what happens is that it expands out. You can see all this erythema expanding out here. So you take a nice dose of intralesional steroids and inject it around here on the outside, go all the way around, and you just repeat it every 4 to 6 weeks, and it'll maintain the condition here for a long time until it burns out in this area, and you have a good way of preventing it from spreading. This is just a bad case of it. Okay. So lichen planopilaris, there's not much to be said other than it's an intense inflammatory reaction by the body. Nobody really understands it. Nobody knows what causes it. It attacks the hair and causes scarring alopecia. It could be associated with lichen planus, and as I said, I've not seen it in association, but obviously it is. And it could really have any appearance, but the one that you just saw is the most common ones. Okay, we're going to talk about pseudopelade, but before I do that, this is kind of a typical picture of a burnt out lichen planus for the most part. Some people describe it as snow. What do you call it? Snow feet in the snow, like when you wear snowshoes, and they almost, to me, it looks like rabbit ears. But you know what? These descriptions are useless. I think that once you've made the diagnosis With a punch biopsy, you just need to treat it and just kind of deal with that in that sense. By the way, when you use systemic antifungals in treating severe fungal infections of the scalp, you can add some topical antifungal creams in addition to the systemic antifungals being used. There's no reason not to, even though probably the systemic antifungal will do the trick. There's no reason not to do the overkill just to make sure that nothing is missed. So in pseudopelade, it's also known as pseudopelade of Broke, and it's really a condition whereby it's an end stage of scarring alopecia. There's really no symptoms or inflammation. It's a burnt out condition, and it's hard to tell what it was caused by. So it could have been caused by like a planet, Polaris, DLE, central centrifugal scarring alopecia, and it's basically an atrophic scarred up condition. So if you get a condition like this, you could see it's uninflamed, looks like it's all scarred up, you do a biopsy, you're trying to find something or another, and it's hard to diagnose it. If you get a biopsy result, stating that the diagnosis is one consistent with pseudopelade of Broke, there's no reason to treat because you're not going to know the cause of what happened. It's like an end-stage scar. In alopecia mucinosa, which is sometimes associated or precedes, and many times it doesn't precede anything, but it can. It's also a scarring type of alopecia. When you do your punch biopsy, what you end up seeing is a lot of mucin in the skin, and it could affect any part of the face, it's usually on the scalp or head and neck. And just know that if you get that biopsy results, it doesn't really mean that the patient is going to absolutely have mycosis fungoides or C-cell or T-cell lymphoma. It just means that they need to be watched out for if they develop any lesions. Sometimes down in the future that erythematous patches or plaques or nodules, having a precedent diagnosis of alopecia mucinosa may make you more concerned about the T-cell lymphoma. So obviously you're going to do a punch biopsy on anything that's new that pops up. And it doesn't look like anything. It's just an erythematous patch that looks like that. It could be in the scalp, it could be on the face, it could be anywhere in the head and neck. Morphia, as it does imply, is a condition of inflammation of the skin. So this concludes our lecture on the scarring and non-scarring alopecias. We will be coming back and talking about conditions of hair breakage. Thank you.